Good morning. So, in today's class, we will discuss about another particular group of organisms. These are called as spirochetes, and they are one of the important disease that spirochetes do cause is called as syphilis. It began in the 1400 to 1500 in the Europe. Initially, the disease was first observed causing an itch in the genital regions. Thereafter, causing severe body ache, pain, and systemic illness. This disease was later on was associated with disfiguring facial features and other organ sites, including the fingers and the limbs, etc. Over the period of time, this disease attributed to a lot of deaths among the human beings. For a long period of time, the origin of the disease, what it caused, was pretty much unknown. So what happened is many peoples, like initially the Italians called it the French disease. When the Russians came to know about this, they called it as the Polish disease. The Dutch called them as the Spanish disease. Similarly, the French they called as the Napoleonian, that is in Italy. Napoleonian disease. The Turks they called it as a Christian disease. So basically, this disease was commonly associated that with sexual intercourse, and hence the xenophobia led to calling the disease against other specific country or even religion. This is the origin of the disease called as syphilis. Now if we look in the history, we will come to know about the emergence of the disease. The first original emergence of the disease can be attributed to two theories. The first theory is the Columbian theory. If you do recall, Christopher Columbus sailed from the Europe and discovered the Americas, which led to increased trade between the New World and the Old World. The Old World means the Europe and the New World is the Americas. And with the trade, many of the diseases were transmitted from Europe to the Americas, and similarly some of the diseases were transmitted back into the Europe from the Americas. One of the disease was syphilis. Now, this was called as the Columbian exchange between the New World and the Old World. Many of the diseases from the Old World, that is the Europe, were transmitted to Americas like smallpox, plague, chickenpox, cholera. But some of the diseases also came back. Among them, very importantly, is syphilis. And one of the diseases that you can see over here is called as the pinta. I'll come to it later. The alternative theory is the pre-Columbian theory. According to the pre-Columbian theory, the people or the scientists, they gave the theory that this disease already existed among the human beings. Only the disease was not recognized. This was later scientifically more evidence were proven by examining the skeletons and the remains in notable places like the Pompeii, which were destroyed a lot early in the history. Nevertheless, whatever may be the theory, what history do we know? So, in the 1495 in Naples, the French king Charles VIII, he laid a siege into the Naples. It was a very violent war, and he was able to conquer the Naples. But following the victory, he found out that a lot of his troops were suffering from a disease, and the disease was so eminent that following the return from Naples, his troops were unable to fight anymore. He disbanded his troops, and from those troops, the disease spread throughout the Europe. It initially started in the Italy, then France, and slowly, as you can see, from 1400 to 1500, it spread over all over the Europe. Now, from the Europe, at that point of time, most of the European countries were exploring throughout the world for search of trade, and a very important part of that was colonization. And because of this colonization, people ventured into the native areas, and obviously whenever the sailors sailed out into the native areas, they intermingled with the native population. Hence the disease, which was earlier restricted into the Europe, later on spread almost throughout whole of the world, including India. Now this disease was initially then called as the Great Pox, to differentiate it from the another very important disease prevalent at that point of time called as the smallpox. The reason was simple. Initial presentation, the disease presented with a rash-like illness. However, unlike the smallpox, mortality rates were much less and the disease was more prolonged. Hence, a huge number of people were actually suffering from the disease. Hence, it was called as the Great Pox. Unlike smallpox, where a lot number of people were affected and most of them died. Another important name that was given to this disease is called as the Great Imitator. Imitator means this is the disease which used to present with various kinds of manifestations. Most of the doctors at that point of time used to get confused with other diseases, and this disease was called as the Great Imitator. Coming to the origin of the disease, it was very much speculated that this disease spread predominantly through sexual intercourse or through discharge of the sexual organs, more commonly seminal fluid. Hence, it was also called as venereal disease. Okay, venereal means from Venus, the goddess of. Later on, this physician, Guillermo Fracastro, described the illness, and while describing the illness, a poem was written about a shepherd. The name of the shepherd was Syphilis, who was believed to be the first person affected by the disease, and according to the poem, was punished by the Apollo, the Greek god. From the name of this poem, the disease was then called as, at that point of time, if we look at the early treatments, initially because of this gross disfigurement of the people affected, various kinds of treatment were utilized. One of the notorious elements that were utilized at that point of time is mercury. Mercury was commonly used directly on the rashes, sometimes inhaled and sometimes applied even orally. Now that we know it should not be used. Nevertheless, you can see this picture in which the patient were laid in a room and mercury vapors were inhaled. Another interesting treatment method was use of guacam. This is a plant or herb that was found in the Americas, and because people believed that the disease came from America, a herbal treatment from the American origin would actually treat the people. Another important development at that point of time, as you can see, there was disfigurement very commonly seen in the oral and the nasal area, leading to sloughing off of the nose itself. That led to the advent of what we know today as plastic surgery or reconstructive surgery and use of artificial nose as well. Now, that was with the history. Now, coming to the modern age, the actual advent in the modern age starts in 1905 when Erich Hoffmann was the first to isolate the causative organism. This causative organism was a spirochete. Thereafter, many modern medications were used, but the most important medication that was found was that this disease was actually treated with the use of penicillin discovered by Alexander Fleming. During the 1950s, the US Marine Hospital treated many patients with penicillin, and thus a complete cure to the disease was found. And at that point of time, it was advocated that this disease could be completely cured and eliminated. But having gone through all of that, today we know that syphilis is neither eliminated, neither eradicated, but still is a big problem statement. Let us look into it why and how. At that point of time, two notorious studies were conducted in the United States of America. One of the most important is the Tuskegee syphilis study. Why we call it as a notorious study? Because at that point of time, please remember that penicillin was the gold standard treatment. Even then, in this study, patients who were affected with syphilis were not treated. Even though in the trial they were told that they were being treated for the disease, they were actually not given the medications. The objective of the study was to see the full spectrum of the disease with all manifestations. It is a highly unethical and inhuman study. Nevertheless, it was conducted. Later on, the US administration did apologize. Similarly, another unethical study that was conducted is the Guatemala syphilis experiments, in which this disease was inoculated into the people. Who were these people? They were the prisoners, mentally ill patients. They were directly injected into the blood, or they were allowed to have sexual intercourse with affected people. The one very positive thing about these studies, although the unethical one, is that today we know the whole spectrum, how the disease can present, at which point of time, and what are the routes by which a human being can acquire this infection. Before going into those, let us learn a little bit about the agent. I have already told you this agent is a spirochete. You can see this picture, it's a coiled spiral organism. This is a bacterium. And why it is called? Because it has got a flagella that is present within the organism itself. Now, you have studied most of the bacteria will have a flagella on the outside of the body attached with the cell wall. But in this case, in the spirochetes, the flagellum is within the body. Hence, it is called as the endoflagella. When this flagella contracts, the spiral movement occurs. More importantly, this was classified into the order Spirochetes in the family Spirochetacea, and this genus was named as Treponema. There are other members of the Treponema. They are called as the Treponema pallidum, subspecies Pertuni, subspecies Endemicum, and Treponema ceratum. Now, please look at that. These are the diseases: yaws, endemic syphilis, and pinta. These are the endemic diseases, and they are also called as non-venereal treponematosis. Why we call it as non-venereal? Because these diseases are not spread by sexual intercourse. They are also called as endemic treponematosis. They were earlier established to be present in the Americas, but a lot of areas today have been established having this disease. Now, among the 4 pathogens, only Treponema pallidum, subspecies pallidum, is transmitted through sexual route, which is the causative agent of syphilis. And another important part is that among all these treponemes, only Treponema pallidum, subspecies pallidum, can regularly breach both the blood-brain barrier and maternal and fetal barriers. This is very important because breaching of the feto-maternal barrier causes what we today call it as congenital syphilis, and breaching of the blood-brain barrier causes syphilitic meningitis. Okay. Furthermore, let us look at some of the most important parts of this bacterium. First is, it has an approximate diameter of only 0.2 micron. Now, why this is significant? Because that is the resolution of a bright field microscope. If something is below the resolution of that, what will happen? We cannot observe them under the microscope. Hence, for direct observation, we need to use a dark field or a phase contrast microscope. Now, this indeed poses a difficulty in diagnosis. Another important aspect that you should remember is the paucity of the protein and pathogen associated molecular pattern. I think you are acquainted with this PAMPS, pathogen associated molecular pattern. These patterns are recognized by the human immune system. And because the number of the proteins are very less in these spirochetes, human body sometimes fails to mount a sufficient immune response to the disease. Hence, this disease lingers on for a prolonged period of time. So, if we look at the pathogenesis, the routes of transmission are mainly sexual intercourse. Sometimes it can also be associated with blood transfusion. If infected bloods are used, contaminated needles, vertical transmission, and even hospital personnel handling patients. There have been numerous evidences gynecologists getting syphilitic ulcers on their fingers when they used to perform pervaginal examination on patients without gloves. Now, How does this infection occur? First, there is attachment, invasion, and dissemination from the local site to the whole of the body. The immune response is predominantly carried out through the cell-mediated immunity, Th1 and interferon gamma as the main mediators. However, antibodies to syphilis are also established. This is important. Both specific antibodies and non-specific antibodies are seen. This is one of the cruxes of diagnosis of syphilis as of today. Now, if we look at the whole spectrum of the disease in this picture, if you study, you can understand the whole spectrum of the disease over here. Initially, there is an exposure. The exposure commonly is a sexual route through the genitals. The incubation period is a pretty prolonged period of time. That is about 10 to 90 days because the turnover of the bacteria is itself about 33 hours. After this prolonged incubation period, the first thing that is seen is called as primary syphilis or also called as chancre formation. Now, what is this chancre? If you look at this ulcer, this is the primary chancre or the primary syphilis as seen on the glans of the penis. This is the, you can see a raised, clearly demarcated ulcer with a well-formed bed, and this ulcer can also be seen in case of females like on the labia, in case of anal canals and oral mucosa, especially with men having sex with men or homosexuals. And whatever may be the location, it is associated with regional lymphadenopathy. If the ulcer is in the genitals, the regional lymphadenopathy is seen in the inguinal lymphadenopathy, and if there is an oral ulceration, the lymphadenopathy is seen in the cervical jugular ulceration. Now, thereafter, the symptoms, even if it is untreated, subsides. And look over here. After the primary syphilis, either the body will be able to contain the infection or not. If it fails to contain the infection, it will spread and we can see early symptoms of neurosyphilis. That means the body is unable to contain and the organism breaches the blood-brain barrier. This happens very less often. However, more often we will find that the patient going into what is called as secondary syphilis. Now, what is secondary syphilis? It is also divided into two phases, early latent or late latent, depending on the period of whether 1 year or more. Now, secondary syphilis very commonly is asymptomatic or mild symptoms like palmar rash, similar rash on the foot and on the back. These are called the syphilitic rashes. These can be seen. It can also be associated with alopecia on the head, loss of skin organelles, and sometimes the ulceration can also be seen, the rashes can also be seen in the oral cavity and even the genitals. Please note these lesions are different from the primary chancre. This is the presentation of the secondary syphilis. Now, another part is if it still prolongs, the disease goes on, some of the patients will undergo what is called as tertiary syphilis. And in tertiary syphilis, you can see the effect is predominantly on the two main organ system is the cardiovascular and the late neurosyphilis, manifesting by affecting almost all organs of the cardiovascular system, including the vessels and the heart. Similarly, in neurosyphilis, even the brain parenchyma are also affected. And on the left hand side, if you can see, if a woman gets infected, there is a high chance that she will if she conceives, the child will also be infected. Now, when and how? The predominant chances of infection are mainly in the stage of the primary syphilis and the secondary syphilis. But in tertiary syphilis, she becomes non-infectious for the child. Why? Because by that time the body is able to mount a significant immune response so that the disease or the organism is no longer transmitted transplacentally. However, remember, a woman in primary or the secondary stage of the syphilis can transmit the disease to her offspring. Now, this is the congenital syphilis commonly associated with hepatosplenomegaly and rashes over the mouth and hands and feet. Now, coming to detection. The best way of detecting a disease is detection of the causative organism itself. Now, in this case scenario, we can detect the Treponema pallidum by these other methods. The first method is called as the dark field microscopy. I have already told you, because the size is less than 0.2 micron, bright field microscopy is not at all helpful. So, what the dark field microscopy does is that we can visualize. But see the problem, we need to take a fresh sample from the patient. Furthermore, the organism can be visualized, but it's a highly labor intensive process. And most of the time, you will not get the patient for doing this test. What is the next alternative? The next alternative is a direct fluorescent antibody staining for Treponema pallidum. What is this? This is a test in which antibody against Treponema pallidum is associated with a fluorescent material, so that if the organism is present, fluorescence activity can be detected. This is much better than a dark field microscope. However, an important part in both these is a negative test does not rule out the syphilis. Similarly, immunohistochemistry can be done and even PCR can be done, but their effectiveness is very much limited. So, alternatively, we are left with diagnosis by serological methods. Now, coming to serological methods, there are two types of serological test. One is called as the non-treponemal test, the other is called as the treponemal test. As the name suggests, treponemal test detects antibody against the treponema itself, whereas the non-treponemal test detects antibodies which are non-specific to treponemas. Hence, they are called as the non-treponemal test. Two important non-treponemal tests are, first is the venereal disease research laboratory test or the VDRL test, and the second one is the rapid plasma reagent or toluidine uninhibited serum test. So, what are these antibodies? Whenever a person gets infected with the disease, the organism starts destroying the human cells itself. Now, this inflammatory reaction causes production of antibodies. Those are not specific for the treponema, but more commonly against the inflammatory response of the organism itself. Now, this test, although not specific for treponema, this test has a very important advantage, is that they can predict the progression of the disease and similarly help in therapy, that is management of these cases. Okay. However, they are non-specific. If we look at the specific test, we have to go for the treponemal test. These include FTA-ABS, that is fluorescent treponema antibody absorption test, or TPPA treponema pallidum particle agglutination test, or TPHA hemagglutination test, or enzyme immunoassay, or chemiluminescence immunoassay. In all these assays, we are detecting antibodies which are specific for treponema, and in this case Treponema pallidum. Understood? Now, when we are talking about syphilis in today's era, another important disease that you should be aware, which is also transmitted sexually, and we are currently in a global pandemic, is HIV. Hence, whenever we are looking for management of sexually transmitted infections, we always have to keep in mind both syphilis and HIV together, because both of them are spread predominantly to the sexual route. Hence, if a person is infected with syphilis or HIV, it is high probable that he or she will be infected with either or vice versa. Now, before doing the test, we need to look at the serological response to the disease. Now, if you look at this chart, this is the progression of the disease. When we look at the production of antibodies, we can see there is specifical treponemal antibodies and non-treponemal antibodies. When I have told you non-treponemal antibodies, that means those are non-specific. More, they predict inflammatory response to the disease, not the organism. Now, these treponemal antibodies, they start to rise after 2 weeks of exposure, and they remain elevated throughout the lifetime. Hence, they can be used to detect primary infection. It cannot detect secondary type, neither can it predict the management or therapy. However, if we look at the non-treponemal antibodies, they are late to arise, that is around about 4 weeks, and see this line, if a patient is not treatment, the antibodies will very slowly come down, but if specific treatment is given, the antibody levels will come down significantly over a period of 1 year. Hence, these non-treponemal antibodies which do come down with treatment can help in management of the cases. I have already told you non-treponemal test commonly used are the VDRL and the RPR. Whereas, the specific treponemal antibody test can be used for detection of the disease at the initial stage. Okay. So, this is the common algorithm, this is not the only algorithm, just try to understand this one. There is also another reverse algorithm that is for a later on. Suppose if we suspect a patient is having syphilis, how will we proceed? First, we need to test whether the patient is having a high titer of RPR or VDR, that is a non-treponemal. If it is negative, high probability that the patient is not infected. If it does comes positive, then we need to test for specific treponemal test. We can use either TPHA, that is the hemagglutinin assay, or TPPA, that is the particle agglutinin. If that comes out positive, that means the patient is actively infected, because both the non-treponemal titers are high and the specific titers are also high. So, this patient must be treated. Okay. And if after the treatment we need to retest with a non-treponemal test, after treatment there is no point of testing with the treponemal test. Now, we need to test with the non-treponemal test to see whether the titers are actually coming down or not. Now, how will we diagnose? The clinical and laboratory criteria is, who is a case of presumed case of syphilis is a person who has a sexual intercourse within the last 90 days with a person who is suspected of having syphilis. This is very important. When you will be taking the sexual history of a patient, you need to consider this fact is the 90 days. Now, for early syphilis, what is the criteria? The first is a confirmed case. When we will say it is a confirmed case? When one or more chancres, that is the genital ulcers, are present, and identification of Treponema pallidum either by dark field microscopy or with a PCR. Now, most of the time we will not have the ability to do both these tests. So, how can we confirm? Then we can only say it is a probable case when reactive non-treponemal or treponemal test, that is a patient present with a genital ulcer and have a non-treponemal or treponemal test as positive. We will call it as early syphilis. In case of secondary syphilis, what we need to do? We need to look for features of secondary syphilis. It includes the macular, papular, follicular rash, condyloma lata, I have shown you the picture on the genitals, and mucosal patches in the oral cavity or the anogenital region. If these are present and if a non-treponemal titer that is more than 4 times is present, we will call it as secondary syphilis. When can we say it is a confirmed case? when we can directly demonstrate the organism either by dark field microscopy or PCR or silver stain. Similarly, for late syphilis, we need to look for, in late syphilis, the organs that are affected are internal organs, including bones, skin, cardiovascular system or the neurological system. Specific systems are affected, and we have the non-treponemal and the treponemal test specific for specific syndromes. Like if we are suspecting neurosyphilis, we need to test VDL in the CSF, okay, or a DNA test with a PCR present in positive in case of CSF. Then we can call it as a CSF, sorry, syphilitic meningitis. So this will be the late syphilis. The last part is the congenital syphilis. The congenital syphilis can be diagnosed either clinically with the clinical manifestation like hepatosplenomegaly, rash, condyloma lata that are present at birth, or we can find the serological test, or to confirm we need to demonstrate the organism. This is the predominant methodology by which we can diagnose a case of syphilis. Please remember the main crux of diagnosis as of today in our setting is predominantly the treponemal and non-treponemal test. Now coming to the treatment of syphilis, well, this is a simplified form of the treatment. In the early syphilis, the treatment is with penicillin. Benzathine penicillin in a single dose or an intramuscular penicillin can be given. Even in the late stages, the penicillin is given for a prolonged period of time, and even in case of neurosyphilis, penicillin has to be given. But only difference remains is the route and the type of the penicillin that is given. For example, if the patient is suffering from meningitis due to syphilis, we need the drug to cross the blood-brain barrier. Hence, there we need to use aqueous penicillin. Okay. And similarly, if we can see, in case of late syphilis, we need to give for a prolonged period of time. Hence, intramuscular benzathine penicillin is given, so that a prolonged exposure of the drug can be given. The same penicillin is also used for congenital syphilis. Now, another important point that you should remember, if a pregnant woman is infected with syphilis, the first step is we need to treat the woman, that is fine. The second step is also we need to prevent the transmission of the disease from the woman to the child. Now, if a patient has an allergy to penicillin, we can use other drugs like doxycycline, but those are contraindicated in penicillin, that's in pregnancy. So in pregnancy, if a woman does manifest allergy to penicillin, we need to desensitize the patient and then give penicillin. Now coming back to the importance of the disease as of today. Now this is the WHO report. Even in around 2000, in the last decade, that is 2010-12 region, we can see in the southeast region that there are a huge number of cases. Even the so-called developed countries do have a huge number of cases. The reason of spread is a twofold. The first is more and more people are involved with consensual sexual activities, and secondly, in today's world, that is the global pandemic of HIV. HIV at the initial stages may not cause any significant disease, but what it does is it reduces the immune status, thus helping other sexually transmitted infection spread more rapidly from one patient to the other. Hence, we can see a more and more number of cases of syphilis as of today. So, today's challenges would be, the first is we need to eliminate the mother to child transmission. This is done in our country. The national or the Ministry of Health and Family Welfare has already formulated a plan called the Sexually Transmitted Infection Plan, and according to which all women who are registered for pregnancy, that is antenatal booking, all women are tested with VDRL test for early detection and treatment in the pregnancy. The goal is to prevent congenital syphilis. Second part is we need to look for specific population which are more prone for these kind of infections. These include commercial sex workers, specific groups who have more sexual exposure like truckers, migrant populations, refugees, and men having sex with men. Because please remember, Treponema pallidum has only human reservoir. There are no animal reservoir nor environmental reservoir. So it comes to the human beings for spreading of the disease. Next step would be to improve the diagnostics. Earlier VDRL was a standard diagnostic modality. VDRL itself has many problems, it cannot be tested outside. Further development led to the test, the RPR or the rapid plasma reagent. This test can be conducted even in the field or the bedside. And next target would be to develop vaccines, although much not progress have been done yet as of today. So to conclude, over the last about 400 to 500 years, we have seen this disease rise, causing a havoc in the early medieval period. After the advent of the antibiotics, we have seen the decline of the disease. But today we see the resurgence of the disease again, especially in the HIV era. Hence, you should be aware with the disease, the various types of the presentations, how to approach the patients, how to diagnose them, and how to manage them. When we were students, we were told as the two diseases which can affect anything may present anyway. One of the diseases is syphilis, the other is a diabetes. Thank you. Any questions?